I would like to invite the first presenter, who is Nadine El Kasis. Will discuss updates in management of early endometrial cancer. Nadine, floor is yours.
Hello, everyone. Thank you for the invitation. I think it's my seventh MEMAGO also. So I'll be speaking about the management of early endometrial cancer, surgical site. So you all know that this is the most common gynecological cancer. Most of the time it's diagnosed at early stages. Obesity is the major risk factor of endometrial cancer. That's why you have increased incidence in premenopausal women. Prevalence, for example, in the USA is 25 cases per 100,000 compared to 3 in the low resource countries. But these incidents will rise because of the increase of obesity. What is early endometrial cancer? So this is when the tumor is confined to the corpus uteri, so it's stage 1A and 1B, and in some resources they add also stage 2. And if you want to take the new FIGO staging, it's a little bit more complicated. So how do we plan the treatment of early endometrial cancer? First, you have to know the exact histopathological type, the exact FIGO grade, the presence or absence of LVSI, if it's focal or substantial, the molecular subtypes. An MRI is a must to evaluate the myometrial depth and cervical stromal invasion and lymph node metastasis, PET CT scan when available or CT scan to look for peritoneal, ovarian, distant, or lymph node metastasis. Also, a thorough preoperative assessment is obligatory. You have to know the family history of the patient, her fertility status, general assessment and inventory of comorbidities, and geriatric assessment when it's the case. Historically, the treatment was done by open laparotomy, and it included hysterectomy, bilateral salpingo-oophorectomy, bilateral pelvic lymphadenectomy, para-aortic also lymphadenectomy, peritoneal cytology, and omentectomy in high-grade types like serous and carcinosarcoma. Now, what are the objectives of the surgery in early endometrial cancer? We have two objectives. The first one is to remove the primary tumor, of course, en bloc. So it will be a total hysterectomy with bilateral salpingo-oophorectomy without vaginal cuff resection. And second, we have to know if the tumor has spread outside the uterus. So we have to do peritoneal biopsies when needed, pelvic washings, even if the cytology is not included in the FIGO staging, omental biopsies, and omentectomy in serous carcinomas, carcinosarcoma, and undifferentiated carcinomas, and lymph node assessment. And of course, the treatment should be performed by gynecologic oncologists. So how do we do it? By laparotomy or minimally invasive? So starting in 1990s, minimally invasive surgery was introduced, and it replicated the traditional goals of comprehensive surgical staging of endometrial cancer. For example, Dargent and Kerlot in France, Childers and Spiritus in the United States demonstrated the adequacy and safety in small single institution studies. Then the GOG determined that a prospective randomized trial should be done to compare laparotomy and laparoscopy. So the first randomized trial was done in the USA. It randomized patients in laparoscopy versus laparotomy, and it included patients with clinical stage 1 to 2A, and including 20% of high-grade tumors. Treatment included total abdominal hysterectomy, bilateral salpingo-oophorectomy, cytology, pelvic and para-aortic lymph node dissection. Pelvic and para-aortic lymph node dissection was omitted in 8% of laparoscopy patients and 4% in laparotomy, and it was significant, but it did not translate into significant difference in final stage or the identification of metastatic disease when comparing laparoscopy with laparotomy. Now, what are the results of this study? So the OR time was, of course, longer in laparoscopy, but the hospital stay was shorter in laparoscopy group. Intraoperative complications like arterial bleeding was not different between the two groups. Postoperative complication were a lot lower in the laparoscopy group. The detection of advanced stage was the same between the two groups, and post-op antibiotic use was lower in the laparoscopy group. And the 3-year recurrence rate was almost the same between the two groups, and the 5-year overall survival was almost identical in both arms. What about the rate and the site of recurrence in the two groups? It was identical in the two groups. So they concluded that the recurrence rate at 3 years, the difference between the two groups was very small, 1%. Laparoscopy does not adversely affect survival. It does not miss metastatic disease, and it does not alter recurrence rates or patterns of recurrence. Thorough surgical staging and histologic evaluation of expected metastatic disease were performed in this trial, and differences were not clinically or statistically different. This is another study, the LACE study, that was done in 2 stages. The first stage was to compare the quality of life between laparoscopy and laparotomy in early endometrial cancer. So they compared it at 1, 4 weeks, 3, and 6 months, and they found out that quality of life was, of course, better in the laparoscopy group. The difference between the two groups was the node dissection that was performed more in the laparotomy group, but that did not translate in a difference in the overall survival and recurrence rate, because as you can see, the disease-free survival at 4.5 years was 81.6% in the laparoscopy group compared to 81.3% in the laparotomy group, with a little bit preference for the laparoscopy group. Another randomized trial in the Netherlands, including stage 1 endometrial cancer and complex atypical hyperplasia. So this trial also compared laparoscopy to laparotomy, and especially safety. There was no evidence of benefit in terms of major complications to laparoscopy. However, benefit in terms of shorter hospital stay, less pain, and quicker resumption of daily activities was better so in the laparoscopy group. What about high-grade endometrial cancer? This is a study done in 2020 in the United States, including 12,000 patients from the National Cancer Database, including grade 3 endometrial cancer, serous, clear cell, and carcinosarcoma stage 1. The 3 years overall survival in the two groups was identical. This is another study, a multicentric database also including high-grade endometrial cancer. The two groups were different in the rate of lymphadenectomy, which was higher in the laparotomy group. The lymph node removed where the number is higher in the laparotomy, and the tumor size was higher in the laparotomy group. However, there was no difference in disease-free survival and overall survival between the two groups, laparoscopy and laparotomy. This is another systematic review of 16,000 women with high-risk early endometrial cancer. MIS showed better perioperative and postoperative outcomes and comparable oncological outcomes than open surgery. What about robot? So the robot-assisted surgery, this is a study that showed that it was associated with lower estimated blood loss when compared to laparoscopy, lower conversion rate, especially in obese patients, and a shorter hospital stay. Another study where they analyzed the survival difference between robotic and laparoscopic surgical staging for early endometrial cancer. They found no difference in disease-free survival nor in overall survival between the two groups. And this is a recent study from the Sloan Kettering, published like a month ago, also comparing robot to laparoscopy treatment of early endometrial cancer. They treated 80% of their patients by robot and 20% by laparoscopy. So they found out also that robot-assisted laparoscopy was not associated with adverse survival outcomes. The complication rates were similar, and they had lower rate of conversion to laparotomy and higher rate of same-day discharge in the robot arm. And this is the ESCO guidelines, where they recommend the use of minimally invasive surgery in early endometrial cancer, even with high-risk endometrial carcinoma. Also, the NCCN guidelines, they recommend the use of minimally invasive surgery in early endometrial cancer. What about lymph node dissection, or should we do sentinel lymph nodes in early endometrial cancer? So also, currently, all these societies recommend the use of sentinel lymph node mapping in early endometrial cancer, all types and all grades that are confined to the uterus, because lymphadenectomy, as per the Aztec trial, had no therapeutic role, but the lymph node status is essential for the decision about adjuvant therapy. And SLN mapping and ultrastaging have been proposed as a surgical method to reduce the morbidity of surgical staging while maintaining the prognostic information of lymph node status assessment. And as per the film study, the use of ICG is better than methylene blue to detect the SLN. And the sentinel lymph node mapping is the standard of care in endometrial cancer, and it was included in the NCCN guidelines since 2018. And why should we do the sentinel lymph node? First, that because the PET-CT has a very high rate of false negative rates of 54%, and even in low-grade superficial endometrial cancer, you can have as high as a rate as high as 11 to 16% in T1, grade 1, grade 2, when you have a lymphovascular space invasion. This is a study done in 148,000 patients. But what's the risk if are we missing isolated positive para-aortic node when we do the sentinel lymph node? All the studies showed that when we have a negative pelvic lymph node, the rate of having isolated positive para-aortic node is less than 5%, even in high-grade patients. And this study in the Sloan Kettering showed that even in low-grade patients, superficial myometrial invasion, they can have 5% to 6% rate of lymph node metastasis. And this is in high-risk patients. They compare two groups, a group who had sentinel lymph node and another group who had a comprehensive pelvic and aortic lymph node dissection in serous and clear cell. And they found out that the overall survival and the recurrence-free survival was almost the same between the two groups. And this is another European multicentric study where they compared sentinel lymph node with another group who had sentinel lymph node with backup lymph node dissection in high-grade endometrial cancer. The backup lymphadenectomy identified only 1% of additional lymph node metastasis, and they had similar disease-free survival and overall survival. Now, this is the algorithm that they use in Sloan Kettering. So they remove all the mapped sentinel lymph nodes with ultra-staging, and they remove also any suspicious nodes. And if there is no mapping on a hemipelvis, a site-specific lymph node dissection should be performed. And the most way of injecting ICG is at 3 at 9 o'clock, superficially and deeply. And this is, so the sentinel lymph nodes was included in the NCCN guidelines, as you can see. It should be used when, and they insist of doing an ultra-staging. What about the ESCO guidelines? The ESCO guidelines, they recommend the use of sentinel lymph nodes in low risk and intermediate risk disease, and usually in intermediate risk and high risk disease, they still recommend doing a surgical lymph node staging, but the use of sentinel lymph node biopsy is an acceptable alternative when done by experts. What about ovarian preservation early endometrial cancer? We can offer this option to young patients who want to retain ovarian function, but we should do salpingectomy when we preserve the ovaries. We have to make sure that there is no gross intraoperative extrauterine tumor spread, no gross abnormality in bilateral ovaries, and we have to do a frozen biopsy on lymph node, and we have to make sure that they are negative. And we can offer this to patients who have only endometrial type histology and who have no inherited predisposition to breast or ovarian cancer and no Lynch syndrome. What about medically unfit patients? In these patients, we can offer vaginal hysterectomy when the abdominal route is impossible, and sometimes we can use a combination of radiotherapy and brachytherapy in high-grade tumors or deep myometrial invasion. In low-grade tumors, we can use as an alternative brachytherapy, and when neither curative surgery nor radiotherapy are possible, we can offer systemic treatment. To end, so the usual treatment is, the recommended treatment early endometrial cancer is total hysterectomy with bilateral salpingo-oophorectomy. Minimally invasive surgery is the preferred route in all the guidelines, and sentinel lymph node with ultrastaging is the standard procedure for lymph node metastasis detection. Ovarian preservation can be offered carefully to some selected patients. Omentectomy should be done in some high-grade tumors, and you should not forget that this surgery should be performed by gynecologic oncologists, and we cannot forget the importance of molecular typing for adjuvant treatment choice in early endometrial cancer, and I think there's a talk about this later. Thank you.